Assume recording. Okay, sorry, I forgot about recording. Okay. What is this? The one at the corner, these two. This one. What is this one? What is this instrument? Nikhil, come on, you've seen me used it hundreds of times. What is this instrument with a notch on here?
Half moon shape periosteum elevator.
Very good. Half moon periosteal elevator. Okay. It's called as moon shaped or half moon shaped periosteal elevator. Where do you use this? Which part of the rib do you use this? Nikhil, which part of the rib do you use this? Anybody wants to tell me where you use this? This is always used to retract the periosteum of the top of the rib. So when you have, first you use a periosteum elevator, you make an incision right in the middle of the rib on the periosteum, use a periosteal elevator to lift it off, use a half moon at the top edge of the rib and slide it so that the top of the periosteum comes out. And then you put a rib respirator below and you slide it anteriorly from front to the back so that the intercostal neurovascular bundle comes off. Did you understand this? Yes or no?
Yes.
So
Yes,
periosteum elevator is for the body of the periosteum. A half moon periosteum elevator is for the top half of the rib. A rib respirator is used for the bottom half of the rib to peel the intercostal neurovascular bundle of the thing. Okay. So this you have told me. What is this?
It's a rib approximator.
Okay, it's Bailey's Rib Approximator. What else can this be used at? There is another instrument like this which has an additional capacity. It's not here. Sorry. Let me just go back. Have you seen something where you can turn this the other way? There is a rib approximator available where you can pull the hooks and turn it facing outside. When do you use that?
to open the
Yeah, so there is, so a rib approximator can also be used as rib spreader. Okay, so when you have a very tight rib, before you can put your FINOCHIETTO, you use this to just gently peel the ribs apart so that you can put your FINOCHIETTO in. Okay, all right, what is this?
FINOCHIETTO retractor.
Okay, what precautions you have to take when you apply a FINOCHIETTO retractor?
It should be open slowly.
Open slowly, number one. What else?
The adhesions, adhesiolysis should be there.
So you have to do adhesiolysis. If you don't do adhesiolysis and open it up, the adhesions will tear the lung. Very good. What else? Where do you apply it? Do you apply it to the anterior part of your incision or the posterior part of the incision, ideally?
Anterior part.
Always anterior part, because the anterior intercostal space is much wider and it opens much more easily. If you apply this to the posterior part of the incision, you will break the rib. Okay. In an 82-year-old lady with osteoporosis, how do you apply this instrument?
Say covering the with the mop and then slowly open the ribs.
Okay, so you have to actually protect the ribs with a mop or a blue towel. Okay, so tell me, why do you apply a blue towel to the edge of the rib before applying this instrument? Why do you put a blue towel in?
Because the
to protect the neurovascular bundle from compression.
The blue towel, yes, it will protect neurovascular bundle. That's the point. What else will it do?
So the stressors will destroy the rib because of the osteoporotic bones.
No. My question is different. My question is, why do you put blue towels on the edge of the ribs before you apply this FINOCHIETTO? Now, forget the old lady. This is just in a standard operation. You'll always find that I put in a blue towel on the top and the bottom, and then I put this. Why do you think we apply blue towels?
Avoid refractions.
No. Yeah, so one is to take care of the ribs. For that, we put gauzes, or we can put mops, as you said. What else? Why do you put blue towels on the top and bottom of the incision before you apply this instrument? Is it making sense, guys? Are you enjoying this, or is it not? I mean, am I being too stupid, or is it okay?
So enjoying, sir.
Good. So tell me why you have put blue towels.
How about the glare
Hmm?
when there is blood in the field?
Sorry, I
So
can't.
now with the
Mukesh, you said something. Tell me, why do you put blue towels? I heard a good word from you.
To avoid glare when there is
So
blood
number
in the
one is
field.
glare. Very good. So you don't want the thing to reflect back on you. It's very shiny. It does upset your vision. One more reason why you apply blue towels. Why do you apply blue towels?
Simply to identify areas.
Sterile blue towels. Sterile blue towels. The key here is sterile. Why do you apply sterile blue towels to the edge of the wound?
To limit exposure to the ambient.
Not the ambient, the skin pathogens. Okay, so you want to actually prevent wound infection and things like that, and you don't want any infective material from the chest to come onto the wound. The main problem is you'll get wound infections, right? If you're doing an empyema, or if you're doing an infected lung. So you always isolate the wound from the pleural cavity, and you isolate the pleural cavity from the wound, both ways. You don't want infection to come from the pleural cavity to the wound, and also you don't want infection to come from the skin to the pleural cavity. All right. That is why it is always a good idea to put a blue towel, a sterile blue towel, before you put this. Okay. So this is a FINOCHIETTO Rib Spreader, the most commonest use rib spreader in thoracic surgery. Okay. Now, Nikhil, you applied this, and unfortunately, you think you've fractured a rib. What are you going to do?
Slowly open the chest.
No, I think you've fractured a rib. So what would you like to do now?
Further slowly opening of the ribs.
Okay, so one of the strategies is you electively put a cut on the rib. Okay, so the fact that you're starting to fracture rib means there's too much pressure or too much tension on the wound or on the ribs, and so you take the FINOCHIETTO out, make an elective cut on the rib, and then open it. Okay, so that the rib fracture doesn't get any worse. What is this?
Sternal retractors.
Anybody wants to have anything different? Give me a name. Come on, guys. This is BURFORD's Rib Spreader.
BURFORD
This is
Rib
not a
Spreader.
sternal retractor. It's a rib spreader. It has a removable blade. So you can put this different depths inside. Okay. So you can have small depths, large depths. You can have pediatric one. Okay. So this is called as a BURFORD's Rib Spreader. What is this?
Scapular retractor.
Excellent. Scapular retractor, right? It's called as Davidson's scapular
Davidson's
retractor.
scapular
Okay.
retractor.
In the exam, we do not expect you to know the name of the inventor, but if you know the name of the inventor, you come out very well in the exams. In the FRCS exams, if you don't know this is called as Davidson scapular retractor, that's okay. But if you say Davidson scapular retractor, it's always a plus point. Okay. So it's very important that you know the name from the word go and keep talking it as if it's second nature. All right. Okay. So what is this? We spoke about it earlier. What is this?
The rib cutter.
The rib cutter. Anybody's name? Oh, say it's GIERTZ-STILLE Rib Shear. Okay, it's called as GIERTZ-STILLE Rib Shear. So anyway, we are recording this, so hopefully you can remember these names a bit later. What is this? What is this? What is the difference between this and this?
This is also rib cutter only, sir.
Okay, whose rib cutter? Okay, this is called as GLUCK. Okay, GLUCK's Rib Shear. Yeah. So that is a vertical operation. This one is a vertical operation. It cuts from the top. This has a horizontal operation. Yeah. But both have the same mechanisms. Okay. What is this? You may not have seen all of it. That's okay. I'm just showing you for having more knowledge. Okay. You don't need to know all of these. But if you come across this, you must know. What is this? Anybody can take it. Okay. I don't mind. This is an interactive session. Okay. This is SAUERBRUCH-FRY. It's a rib shear. It's still a rib cutter. Okay. All right. What is this?
Lung retractor.
Whose lung retractor? Whose lung retractor?
Duval's.
Arif?
Allison's.
Okay, it's Allison's lung retractor. What do you have to do when you want to retract lung with this? What precaution you have to take? You can use it as it is, but is there another way of using this?
The mop over the lung.
Good. Put a mop over it. Put a mop over this or put a mop over the lung and then retract it. So it doesn't slip. Okay. And you don't cause damage to the parenchyma of the lung. Okay. What is this? I can't hear you. Sorry. It's Duval's lung retractor. Okay. It's lung forceps for grasping the lung and retracting the lung. Okay. What is this?
Rampley sponge holding forceps.
Okay. Tell me 2 uses of Rampley sponge holding forceps in thoracic surgery. 3 uses actually. 3.
Sir, holding the lung.
Okay, good. Gentle retraction and holding the lung. Good. 1. Number 2.
2 is using a gauze piece. It can be used as a pressure point.
What is that called as? Common word used for
sponge on a
gully.
swab on a stick. Okay, swab on a stick. Yeah, it's called a swab on a stick. Yeah, so you're right. What else can you use a Rampley's forceps for?
Sir, for lymph node grasping.
Okay, lymph node grasping. What else can you use it for?
Adhesiolysis or taking out the cortex.
So for decortication, you can use a Rampley's forceps. Okay, what else can you use it for?
Sir, before starting operation, painting and draping.
Okay, what else can you use it for? What else can you hold with it? What surgeries you do in the chest where you got to take out things from the...
Esophagus can be held with this.
No. Esophagus, you don't want to hold. It will get crushed, man. You'll get esophageal injury with this. Lung is very forgiving. Esophagus is not forgiving. So that is incorrect. What else do you hold to take out, man, from the chest? One is you said adhesions. What are below the adhesions? What is below the adhesions? In an infective case, what do you use this for?
Hydrolysis, empyema.
Yeah, all the empyema content, no, all the muck that is there, you use it to grab it and take it out. And what else? Cardiac surgeons will tell you what else you use this for. What do the cardiac surgeons cause very often?
Remove the
Sir, clots, sir.
Clots, absolutely
Clots,
correct. They cause bleeding and clots. So this instrument is used for grasping the clot and bringing it out. And one last use, if you tell me, I'll give you 10 out of 10. One last use in VATS. Where do you must have seen me use thousands of times this instrument in VATS on the ports. Where do I use this instrument? For correctly placing a chest drain. Okay.
Chest.
Yeah, you can grasp the chest drain with this instrument and direct it through your port into the chest, and you hold it with inside the chest, you hold it and allow the lung to re-expand so that you correctly place the instrument. Okay. What is this? Come on.
Cross clamp. Aortic
Cross
cross clamp.
clamp. Yeah. What else? Yeah, agreed. What else? In thoracic surgery? Okay, it's a vascular clamp. It's a DeBakey's vascular clamp. Where do you use it in thoracic surgery?
It's a pulmonary artery, bleeding pulmonary artery.
Okay, so where do you use this? In a bleeding pulmonary artery, I'm going to ask you, what are your strategies? You are doing a lobectomy and you've just caused a bleed. What are your strategies for management?
Sir,
You're a consultant surgeon doing a lobectomy. You are doing a right lower lobectomy. You just caused bleeding from the common basal artery. What are you going to do?
Sir, I'll put a pressure.
Good. How do you put pressure? What are the ways to
use
put pressure?
Sir, using a sponge on sponge stick or mop.
Swab on a stick. Peanut. Sometimes you can use a peanut if it's a small hole, or put a mop on it. Okay, so that's one. You've done that. What is the next strategy that you're going to do?
Sir, I'll inform the anesthetist.
Excellent. Excellent. Very good. In the exam, I want you to say that. I will inform the anesthetist that there is bleeding. What else will you do?
Then ask the nursing staff and the anesthetist, is the blood available? If not, please get it immediately.
Good. What else will you do?
If every instrument is all instrument and available, and is there any senior surgeon?
Call for help. Call for help. The word you have to use is, I will call for help. Very, very important. In the exam, what we are trying to see is, are you a safe surgeon? That's all I want to know. Are you a safe surgeon? Complication is not a problem. But if you do not call for help, you're no good. Okay, what else? How will you stop the bleeding? Pressures and all that are there. He's continuing to bleed quite dramatically. What are you going to do?
Then once the help is available, I'll have a proximal control.
Okay. Before putting these clamps or proximal control, what are you going to do with the blood in the chest? Are you going to let it all be sucked out?
No, sir. If the cell saver is available.
So you ask for cell saver, no?
Cell saver.
You have to ask for a cell saver. Okay. What else? Now what are you going to do? How do you get proximal control? Tell me tell me 3 strategies for getting proximal control.
Sir, one is extra pericardial, another is
excellent. So one is extra pericardial, second is intrapericardial. Well done. Well done. What will you do to extra pericardial? How do you get proximal control extra pericardially?
Sir, mediastinal pleura is further divided towards cranially, and retracting the superior pulmonary vein downwards, I can hook around the pulmonary artery.
Okay. Good. And then when you're hooked around the pulmonary artery, what are you going to do?
Apply a clamp.
Apply a clamp. So one is you can actually apply a clamp. That's one way. What is the second way you can get control?
Bulldogs.
Main PA bulldog will not work. Your vascular
Not
clamps are what you need. What else?
Cross
What other
clamp.
ways? You can apply clamp.
So,
We've said that whether you use a cross clamp or use any other vascular clamps. So one strategy is to apply the clamp. That's good. What else can you do to get proximal control? You have dissected the pulmonary artery. How do you get proximal control?
slooping it,
Loop.
passing a sloop.
So you will put a sloop around it and loop the sloop. Do you know what I mean? Loop, you do 2 turns and then put a clamp on it. Okay. All right. Second. Third, what else can you do? What is the third way to get control of the proximal pulmonary artery with a tape? What do you do with the tape? Come on, cardiac surgeons, every day you do this.
Snug it. Snuggers.
Snuggers, use snuggers. So instead of a sloop, pass a tape, a tape, and then snug it and use a snugger to push it down, and that will give you proximal control. These are all exam questions, huh, Nikhil? Whatever I'm asking you is all
Yes,
exam questions. So you have to know these things, okay? All right. For you to be able to get proximal control, what do you have to do before you can do all these maneuvers? If you're operating by VATS, what else you have to do before you can do all these maneuvers?
Sir, if I am operating by VATS, I'll convert it into open procedure.
Thank you very much. So you have to convert your VATS into an open thoracotomy, get wide exposure, and then come to the hilum and try to do that. Okay. Very, in an exam, you guys should never say, I will get control by VATS. Never, ever, ever. It's only for experienced people like me who have to say these things. You cannot say it. You should say, if I'm doing a VATS lobectomy and there's bleeding, I will put gauze or I will put swab on a stick, get pressure, and I will quickly convert to open thoracotomy. I will call for help. I will involve the anesthetist and I will try to get proximal control. Okay, that is what you have to say. Is that clear? Well done.
Yes, sir.
Well done. Okay. Tell me, what is this?
Satinsky's vascular clamp.
Okay, it's an aortic clamp. All right. When do you use this? In thoracic surgery. In cardiac, I know you use it on the aorta. When do you use it in thoracic surgery?
Pulmonary artery.
Yes, when you get bleed and you want to put a side biting clamp on it to be able to suture it, you use a Satinsky's clamp. Okay. All right. What is this? What is this?
No, sir.
See the previous one and see this.
Satinsky.
What is difference?
This also
between
Angled
this?
Satinsky clamp.
It's a DeBakey's aortic
DeBakey,
clamp. Okay. If you know it, you know it. You don't know it, that's fine. I don't mind. What is this? Okay, this is a bronchial clamp. Okay.
Clamp, same.
So this is a aortic. This is a vascular clamp, but this is a bronchial clamp. You see, in a bronchial clamp, there's just one straight line in there. In a this thing, there is horizontal serration. This is one vertical serration. When do you use a bronchial clamp? Bolo, Nikhil, you are the exam going guy. You have to tell me the answers.
Sir, before dividing the bronchus, we'll clamp it and see for the extension of another lobes.
You want to clamp it to make sure that the other lobes expand. Okay, very good.
Yes.
That's right. Where else have you seen this being used?
In the absence of staplers for
Yeah, in the absence of staplers in open surgery, you put the clamp, you cut the bronchus off and suture it over this. Yeah. So this is used. If you don't have staplers and you're doing open surgery and you're going to suture the stump with a thing, then you put the bronchial clamp and just cut off the distal end and let the specimen go. And then you put sutures on the clamp. Okay. Why do you want to do that?
To prevent spillage of the opposite lung.
Absolutely correct. To prevent spillage into the pleura. You don't want to create spillage in a pleura. Otherwise, you will get infection. And you know that endobronchially, it's not a clean, it's always a contaminated thing because you're with the outside environment, air you're breathing in. So that's why you clamp the bronchus. Okay. What is this? Sorry, the picture is a bit blurry. What is it?
This is also bronchial clamp.
Yeah, it's a different type of a bronchial clamp. It's called a SAROT's bronchial clamp. Okay. So we spoke about posterolateral thoracotomy. We said informed consent. We've spoken about this, spoken about latissimus dorsi. We always try to spare the serratus, open the thoracodorsal fascia, count the fifth intercostal space above the sixth rib, elevate the periosteum, open up the intercostal area, put in a FINOCHIETTO retractor. Okay, so this is what you do. Yeah, incision, and then periosteum elevator. What is being done here?
Sir, intercostal muscle preservation.
Flap harvest.
Flap harvest. Why is this surgeon harvesting the intercostal muscle flap?
Sir, anticipating the need of covering bronchus.
Okay. So now my question is, when do you need to cover the bronchus?
Sir, in case of pneumonectomy or a lobectomy in an infected case.
In an infected chest. Okay. One. Where else do you use
Post
a
radiotherapy
intercostal?
or
Yeah. Post what? Good.
radiotherapy when
Okay.
vascularity is reduced.
So post radiotherapy, agreed. What else? Where else will you use an intercostal muscle flap?
Endobronchitis. Endobronchial involvement.
Endobronchial tuberculosis, always. Yeah. When you have endobronchial tuberculosis and you're doing a lobectomy or you're doing any major resection, it's always good to put a flap on it so that you don't create bronchopleural fistula. Where else? What other conditions will you use this in?
Doing a pneumonectomy?
Do you do it for all pneumonectomies? You can.
No,
There's nothing wrong with that.
Right-sided, yeah.
Okay, right-sided
Right
pneumonectomy is
pneumonectomy.
fine. Agreed. What else? Specific conditions with pneumonectomy. Where do you do it? So one is radiotherapy. I completely agree. What else?
Neoadjuvant chemotherapy. Patients have had
Yes,
neoadjuvant
patient who has had
Yeah.
chemotherapy. One more condition I want to know: when you will use an intercostal muscle flap.
Sir, bronchopleural fistulas.
We've said that infected space with bronchopleural fistulas. What else? Any more systemic conditions where you would want to use a intercostal muscle flap?
Immunocompromised patient.
Immunocompromised patient. Absolutely correct. Any patient who's immunocompromised, whether you're talking about HIV or long-term steroid use, diabetes, chronic kidney diseases, all of this, you must think of using an intercostal muscle pedicle flap. Now, my question to you is, on which artery is this flap based? And is it anteriorly based or is it posteriorly based?
It's
Two
a posterior intercostal. It's a posterior division of intercostal artery.
Okay, so it is based on a posterior thing of intercostal artery. Why do you base it posteriorly and why not base it anteriorly?
Sir, the blood supply is coming from the posteriorly.
No, blood supply comes both sides. It's a communication. There is an internal mammary artery, no, in the front.
Yes, sir.
Blood
Aorta
supply
is the
comes
larger
from all
artery.
sides. Sorry?
Posteriorly it arises from the aorta, which is the larger artery than anterior intermammary artery.
Yeah, but more, what is the reason for basing it posteriorly rather than anteriorly?
Sir, it can be swiped in either way.
It can be done either way. That is the correct answer. It can be done anterior or posterior, but commonly we base it posteriorly. Why?
So there won't be a tension on the
Absolutely right.
blood supply. Yeah,
Absolutely right. If it comes posteriorly, the distance to the hilum is shorter.
Short term.
Yeah, it's a shorter distance to the hilum, so there will be no tension on the flap. It falls naturally. And so that is why it is usually based posteriorly, not anteriorly. If it is based anteriorly, it has to cross the whole mediastinum to come to the hilum. And that is difficult because when the lung re-expands, it can just pull the flap off. Whereas if it's posteriorly placed, even if the lung re-expands, it just pushes it against the chest wall. Okay, what are the other muscle flaps that you can use to cover, sorry, not other muscle, what are the other flaps that you can use to cover the bronchial stump?
Sir, the extra thoracic muscle.
Which ones? You have to tell
Yeah.
me the names, no? This is
We
flap
can use a
list. Sorry?
plural flap.
Plural flap, yeah, not so
Yeah,
common.
we can use
Tell me the
also
common
omental
ones.
flap.
Yeah, before
Omental
omentum,
flap.
talk about the chest, no? Talk about the chest wall. What
Serratus.
We can use the pericardium.
you can use
PMMC.
pericardium. Well done. So you can use pericardium. I agree with you.
Yes.
What else? I agree with omentum. There's nothing wrong with omentum. I want you to talk about common things first, because in thoracic surgery, if you start taking omentum, then it is a very big operation, 2 incisions. So what are the common flaps available for you during a lobectomy? So one is pericardium, one is intercostal muscle. What else?
Pericardial pad of.
We said that pericardium, pericardial pad of fat. What else?
Then extra thoracic muscles.
I can't hear, the noise is ringing. Somebody give me a clear answer. What do you mean
So
by extra thoracic muscle? Give me a name, yaar. Come on.
Pectoralis major muscle flap, serratus anterior
No.
flap.
Pectoralis
anterior
major
flap.
you don't use for bronchial stump. You use pectoralis major when you want to fill up the cavity. But
Cavity.
bronchial stumps, what do you use? If you have done a sleeve lobectomy and you want to just put a flap around it, what is the best one to use in a sleeve lobectomy besides the intercostal muscle flap? What is the other one?
Serratus anterior.
Serratus anterior. Absolutely right.
Mm.
Serratus anterior flap. You use very often serratus anterior flap. Now, in addition to that, what are the tissues which you can use? Ahmed said something. You can use omentum in an infected
Pericardium,
space.
pleura.
You can use even latissimus dorsi when you are filling in a space post pneumonectomy infection. You want to fill up the space with healthy tissue. You can use pectoralis muscle, or you can use tram flaps. Okay, you can do tram flaps and swing them around. One more flap, if somebody tells me in a pneumonectomy patient that you can use. Which is available for you locally. Phrenic nerve pedicle, okay? If you use the phrenic nerve along with the neurovascular bundle with the fat, just this, because you've done a pneumonectomy, you of course want the diaphragm to come up and fill up the space. So you dissect the phrenic nerve, cut off at the base and swing it around and put it onto the pedicle. Okay, so lots of flaps that you can use in the chest. Forget this. This is just we were. How do you close a posterolateral thoracotomy?
Sir, before closing, we'll do a sign out. Label the specimen labeled. All mop instrument count are correct. Hemostasis has been achieved. Then approximating the after sighting the drain, approximating the rib with the pericostal or intracostal sutures through the rib sutures.
Okay, so what is a pericostal suture and what is a transcostal suture?
Sir, in pericostal suture, we pass the suture material along the rib.
Along or around the rib? Around the rib.
Around the rib.
What suture material can you use?
So the Vicryl number 1.
Okay, number 1 Vicryl. Anything else? What else can you use?
Can be used PDS also.
Okay, PDS. What else? If you want a stronger suture material, what else can you use?
So, loop ethylon.
Ethibond.
Ethibond.
Okay,
Ethibond.
ethibond is used sometimes. And in the old days, what did they use in the old days? Which they still use in cardiac
Catgut
surgery.
suture.
Sorry,
Okay. Is it catgut suture? Not
Steel
catgut.
wires.
No.
not catgut. What did they use in the old days?
Ah,
Steel
sorry,
wire.
the sternal
Steel wires, sternal wires. Yeah. Sometimes in the old days, they used to, you can use sternal wires on a chest wall, particularly when you're worried about the osteoporotic bones and all that, you can do that. Okay. What is a transcostal suture? What is first tell me what is the problem with a pericostal suture?
Sir, it the neurovascular bundle get trapped into the suture material.
So it can compress on the neurovascular bundle. So what is a transcostal suture?
So to avoid trapping of the intercostal bundle, the lower rib, the suture material pass through the lower rib using
How
a
do you
needle.
pass the suture material through the lower rib?
Sir, using a hard needle or through using a drill to make a hole into the rib.
Yeah, hard needle usually doesn't go through the rib. You usually have to use a drill to make holes in the middle of the rib and then pass the suture material. Okay, good. Okay, so what is this? This is the guy making the drill. Can you see that? See this?
Yes,
He's
sir.
making a drill, using a drill to make the hole. And then on there, he will pass the suture material through it. This looks like ethibond to me. And then he comes out. So muscle sparing, we said, we described it. Okay, we'll talk about it. So just to talk about muscle sparing, this thing is you always raise the flaps. Okay, Nikhil, you don't cut any muscle in this. So what you do
Yes,
is
sir.
you identify the latissimus and you have to dissect underneath the latissimus using a diathermy. Okay, you have to make this flap. The whole muscle has to be lifted off the chest wall and then retracted with a suture. And then you open
Yes,
the
sir.
thoracodorsal fascia. Okay, so you don't cut anything. And when you do a muscle sparing thoracotomy, you normally have to do two. You have to put two separate retractors. Okay, because the muscle keeps falling back in. So one retractor holds the muscle back and the second retractor pulls the rib apart. Yeah. What is the advantage of muscle sparing thoracotomy?
Less pain, cosmesis.
Yeah,
Better ventilatory
less
function.
pain, less inflammatory response. Okay, but what is the main thing? I think Arif said something. What is the main?
Ventilatory function.
Absolutely
Lung
right.
mechanics are maintained.
The mechanics of the chest wall, not the lung. The mechanics of the chest wall are maintained.
Chest wall.
So there is some suggestion that the post-operative recovery is better with not cutting the muscles. Okay. Now somebody tell me auscultatory triangle and the Petit's triangle. Come on. How do you do this auscultatory triangle thoracotomy? So you didn't tell me that triangle, Petit's triangle. Come on, tell me the Petit's triangle. Tell me the three borders of the Petit's triangle.
Medially by the lateral border of trapezius.
Thank you.
Inferiorly
Internal
by
iliac
medial.
crest.
Iliac
Ah,
crest.
sorry.
No. Iliac crest.
No,
Kidhar
sir.
hai, Baba? Oh,
Sorry.
hello.
So he was
We are
talking
in the
about lumbar
chest.
triangle.
We are in
Lumbar
the chest.
triangle.
Okay.
Lumbar triangle.
Okay, I'm talking about the auscultatory triangle. Okay, so latissimus dorsi, and what is this?
The middle edge of the
Middle edge of the
scapula.
Medial border of the scapula. Okay. So now somebody describe to me auscultatory triangle thoracotomy. Really quickly. When do you do it? When do you do auscultatory triangle thoracotomy?
In bulectomy.
Yeah. Bulectomy and pleurectomy. In the old days, when we were trying to do open surgery for pneumothorax, we used to actually do in the auscultatory triangle. Somebody just give me a quick description of auscultatory triangle thoracotomy. Nikhil, go ahead.
Sir, incision, skin, incising the skin.
Okay, good.
Auscultatory triangle,
Yeah.
cutting the subcutaneous tissue fat, and then retracting the latissimus dorsi lower down to
Do you need to
caudally.
retract the latissimus dorsi? In an auscultatory triangle, you don't need to retract anything because there's a hole, there's a gap in that area. Yeah, so there's a gap. So you make an incision here and you directly get onto the thoracodorsal fascia. You understand that? Because this is done for pneumothorax and all that. You might retract, dissect a little bit, but usually you don't need to do that. All you have to do is just get into that thoracodorsal fascia and then get onto the rib and make your incision. Yeah, and you're in the chest. Okay, so that's the advantage. Again, double. This is closure. Okay. So I won't talk about this. This everybody knows a lot about it. What is this? Sternal Saw. Okay. What is this? Tell me what is this instrument in thoracic surgery, in cardiothoracic surgery?
This is also sternal saw.
Oscillating saw. Oscillating saw.
Auxiliary saw.
So when do you use this and when do you use this?
Oscillating saw is used for redo sternotomies.
Okay, for redo sternotomies. So now my question to you, Arif, you're not exam going. Otherwise, I would have loved to ask you this question. So, but the problem is Nikhil is not cardiac exam going. Is there anybody who's cardiac exam going? Olaniran, are you doing the FRCS?
Yes, sir. Next year I do.
Okay, so tell me, I'll ask you this question, Olaniran. Tell me steps of a redo sternotomy.
Okay. After draping the patient,
Yes.
I would initially want to prepare the groin because
Excellent.
I may want
Well done.
to cannulate through the femoral artery and the vein. So I would prepare the groin. I would, you see that I can put, if I'm definitely going to use the groin, I would put my cannulas there, but I won't go on bypass. I would open the skin and then use the atomy.
We lost you, Olaniran.
Before
we lost you at diathermy.
before,
Just tell us again what are you saying? Yeah.
So I said I will use the diatomy to get onto the sternum to create a space for my sternal saw, the oscillating sternal saw. Before, this is what I've seen practiced. Before opening the chest, I would ask the perfusionist to go on bypass so that I can decompress the right ventricle. And then I would, in a forward and backward movement, I would slowly get onto the sternum and open with the oscillating saw. And once I do that, once I open gradually, I would have to slowly, with the help of the assistants, slowly with the diatomy, cut the fibrotic segment under the sternum.
Okay, Olaniran, would you cut the whole bone with this saw? In a redo?
I would do it stepwise. Yes, sir. In the first, I'll cut the anterior border first. Anterior
table.
Of the
anterior
sternum.
Table is called. As,
anterior table of the sternum. And then while doing that, still maintaining that I'm far above the right ventricle, I would then go onto the posterior table slowly, and then I would open slowly, and
if
then with that,
if you feel uncomfortable opening the posterior table because you're worried that the RV may be too close, what can you do? How will you open the posterior table?
I can put a retractor to the lower, after creating space at the lower edge to up to the CV sternum. I can ask the assistant to retract and then slowly with diatomy, after retracting, lifting up, I can use can I go back to that? So I can use strong antibody stitches, 2 on each side.
Okay.
Go to the anterior table with the assistant pulling and 1 on my side, pulling anteriorly. Then I will use the sternal saw to get onto to cut the posterior table of the sternum.
But I'm saying if you're worried that the posterior table may be stuck to the RV, suppose it's a 4th time redo, okay? So you're really worried that the RV may be stuck. How will you access the posterior table of the sternum in a 3rd or 4th time redo? I like you are going into the Ziffy sternum, but what do you do from there?
Going into the system, I can put. Okay.
Can you use a
Did I
scissor?
use struck?
Can you use a
Yes,
scissor?
yes, sir. I can.
Yeah.
Yes, I can use the scissors to
So
cut.
one of the
and then
things,
slowly,
strategies is
yes,
at the Zephyr sternum, you start cutting with a scissor, the posterior table,
yes, sir.
and then dissect
Okay, sir.
underneath as you're going, and then keep
Underneath.
cutting and
Yes, sir.
dissect. One of the things that you
Understand.
forgot to tell me in the arrangement
Yes,
for
sir.
these patients is that you will attach external defibrillator pads.
Yes, sir.
Okay, because these are cases
put
who are
aside,
likely to arrest or likely for things to go
yes,
haywire.
sir.
So you want to have
Yes.
access for external defibrillator pads
Defibrillator.
in these
Yes, sir.
patients. Yeah.
Okay.
So one is
Yes, sir.
prepare the groins. You may open the groins. You may even cannulate the groins. All of that is correct.
Yes.
But don't forget to mention attach external defibrillator pads. It's important.
Yes, sir.
Yeah, because these
Yes, sir.
guys arrest.
Yeah.
Okay, well done.
Yes, sir.
Very well done.
Absolutely.
Okay. So this is the circular sternal saw used in redo. What is this?
It's the sternal retractor.
Good. This is a Morse sternal
Exactly.
retractor.
Morse
It's called as Morse's sternal retractor. Okay. This is different from a FINOCHIETTO because this has got movement on this one as well and movement on this one as well. So you can adapt it to the shape of the sternum. So this one will go onto the manubrium sterna and this might go onto the sternum. Okay. So you're on the body of the sternum. So this can adapt. This is FINOCHIETTO. We said that this is a Morse sternal retractor which looks very much similar to a FINOCHIETTO thoracic retractor. What is this? Tell me what is this?
IMA retractor.
This is
Delacroix Velocor IMA retractor.
Okay. Delacroix Chevalier IMA
Chevalier.
retractor. Delacroix Chevalier IMA retractor. Tell me, how do you apply a IMA retractor?
so there are two individual blades on the left side, which goes below the posterior table of the sternum.
Oh,
So
sorry.
you first,
Sorry, yeah.
yes, sir. You first start with the one on the right, which goes to the edge of the sternum
This
on the
one or
right
this
side,
one?
and
This one.
the one on the right side, sir. Yes, sir, this one goes
Okay.
to the edge of
Yeah,
the
sorry.
sternum
Okay. Yeah.
on the
Good.
right side.
Yeah.
On the right side, and then these the two individual retractors are like blades. One goes proximally at the manubrium, while the other one is close to just before at the lower end of the sternum, before the sternum, after dividing below the posterior table. And then slowly with the handle, you open it while the left side goes up for you to be able to get into the internal mammary artery.
Okay. So the important thing to remember is that all retractors open horizontally. This is the only one which opens vertically. Okay.
Vertically, yes, sir.
This opens vertically because you want the chest wall to go up to see. Now,
Yes,
my question to you is this used for the right side? What you're seeing in front of you, is this used for the right or the left?
This is for the left internal mammary artery, but
So
then it can also be
next
used for the
question
right.
is, how do you use it for the right IMA?
I would have to turn it the other way around. I would turn it. So the bar will be approximately.
Where will this bar
at the
be?
manubrium edge.
So this bar will be on the manubrial edge. Okay, good.
Yes, at the manubrial edge.
So you turn it the other way around.
The left.
So the mount is completely different. You have to change the mount around. Okay. And the way you applied, you have to turn it around and apply it around. Good. Well done. Well done. Okay, good. What is this?
These are snuggers for.
Okay. Where do you use
snuggers for
common indications for use of snuggers?
Aortic cannulation.
Good.
Either the vena cava cannulation of the
good.
right atrium.
What else?
Also to gain a proximal and distal control in hemostasis.
Okay, good.
You can also use that.
So vascular snuggers. Okay. So let's forget this median sternotomy. I won't talk about this. How do you close a median sternotomy? How do you close a median sternotomy? You can take it, Olanira.
Yes, sir. After achieving hemostasis, proper hemostasis, and then the swab count and everything has been done, the needle count has been done, and I would apply the sternal wires from the left side, coming, since I'm right-handed, from the left hand coming to the left side. So I can either do a single 8 sternal wires, or I can use the figure of 8 or the.
Keep talking, yeah. Yeah,
yes,
okay.
I can use the figure of 8 or the single sternal wires, and after that, I will check below the posterior table of the sternum again on both sides to confirm that there's no, to check for hemostasis, be sure that there's no bleeding, and then I would have to inform the team that I'm closing the chest so that everyone is aware and the proper counts have been done. Yes, after that, I would then apply pulling both up. I would have to, with the pulling both edges up. Then I would tie each of the sternal wires, and then cut the extra sternal wires, and then with my needle that I used for the sternal wires, I still need to pull it up to ensure proper apposition, to make sure that the edges are not scratching against each other.
Yeah, good. Well done. So my next question to you is, when do you use sternal bands?
Osteoporotic sternum.
Just wait. Let him continue. Nikhil, let him continue.
Yes,
when
sir,
do you
sorry,
use
sir.
sternal bands?
Maybe in elderly osteoporotic.
Okay, good.
sternum.
So one elderly
Yes,
patients. What else? Other indications for using sternal bands?
And I think patients who are obese, or I'm not sure. So,
okay, yeah, you can use it in big
I'm not sure,
patients.
sir.
You can use in obese patients. You can use in osteoporotic bones. Okay, patients with osteoporotic bones. So continue, Olekaran. Hello, you've logged out. What happened? He got upset with us. Okay, is he still with us or he's logged out? Okay, he's logged out, probably by mistake, I think. So Arif, not Arif, Nikhil, if you have fractured the sternum during a sternotomy, what are you going to do?
So whether it is single or multiple fracture, it depends on this. If it is
okay, it's not fair because you have not seen this. Arif, quickly
Figure
tell
of
us
8,
what do you do.
Figure of 8.
Yeah, okay. Tell
Figure
me
of
what
8
you do.
suturing or figure of 8 sutures or the Robbie-Shake in which.
So tell me, what is Robbie-Shake's technique? That's what I wanted to ask you. How do you do Robbie-Shake's technique?
You two parallel steel wires are taken parallel to the sternum onto the ribs also, sir, on both sides of the ribs, interlocking with the ribs in the costocartilage junction, and then the sternal wires are taken incorporating these two sternal wires.
So in a what is the advantage of the Robbie-Shake's technique?
It can be done when the sternum has been unevenly cracked or fractured, or sternotomy was not median, or there is multiple ribs have been entered.
Yeah, so why do you do Robbie-Shake's technique? What is the advantage of Robbie-Shake's technique? That's what I'm asking you.
It may help in maintaining the sternum stability of the sternum.
How?
By reinforcing.
No, why is this vertical? Why is this vertical wire placed in a Robbie-Shake's technique?
This acts as a reinforcement to the broken sternum. Sternal wires these vertical sternal wires reinforce the.
No, this vertical sternal wires cannot do anything to the sternum. What do they do?
No, sir.
They form the strut for this cross sternal wire. So all this pressure of the sternal wire falls on the vertical sternal wire. So there is no cutting of the bone. Because you've put vertical sternal wires and then you start closing these, The advantage of Robichex is all the pressure of this is borne by these vertical sternal wires. So you do not cut through the bone. Particularly in an osteoporotic thing, while you're tightening, one of the problems is you might actually cut through the bone. Yeah. So that is why you put the vertical thing so that you do not cut through the bone. What happened, Olaniron? You were upset with our questions.
Sorry, no, sorry, sir. My network, a call came in and then.
That's all right. Don't worry. Come in. Come in.
Yes, sir. Sorry, sir.
Yeah. Hi. Something else? 1 minute. Just wait. Okay. Just hang on, guys. Yeah. Tell me. Yeah. Yeah. Okay. 1 minute. Just sit down 1 minute. Sorry, guys. I just realized I had to be in another meeting, and I did not.